having an access is a huge help. But this session, you can ask me any question. It is like a town hall. Mon khule prashno karen. So no problem. 70-year-old, diabetes, hypertension, hyperlipidemia, and then previous stent, had a permanent pacemaker, chest pain, lateral ischemia. Now I tell you, I was telling in the main session, we are now, I'm not sure how many you are getting, we are getting increasingly CTA and come to the lab. Nothing. And in the US, and I'm scared about doing intervention in stable coronary. I'm telling you that in the stable coronary, doing a PCI, you need to have some criteria in terms of meeting the appropriateness criteria. It is not, I just wanted to tell you this, that I don't want to hide it. There is one guy in Baltimore went to jail recently. I don't know you heard about that because of inappropriate PCI in the stable situation. In the large database in the US, acute coronary syndrome, and then question about inappropriateness, they categorize in 3 groups: appropriate, proper documentation, inappropriate, and indeterminate. So if your hospital number is inappropriate too much, you will be investigated. And then they will look into the individual operator. And it is very important because you take money from the government. Now, Impella, we are also criticized, and I need to be very frank with you, there is incentive for the operator. You see, reimbursement is there, CMS, and there is a high-risk PCI, call it high risk, and then make it a case for Impella. But we have done this without the Impella in the past. And I'm not going back, but when you think that it is needed, I usually tell my fellows and the new attendings that you need to document that there is enough reason to put an Impella. Anyway, so this is the cath, and on the right side is okay, but if you look at, what is your comment on the left? I don't have all the clips. Whoever put this for me did not give me all the clips. He probably thought that I don't need it all. So ostial cert, what do you think? Tight?
Tight.
So should we do it?
Yes.
Why?
So if symptomatic patient.
Symptomatic is not good enough. And in appropriateness criteria, symptomatic is not good enough unless you document clearly that exertional angina, and over time the endurance has gone down, right? And then they will ask, did you try all the anti-anginals? So we participate in the national registry. It may not be good enough. But here, there is a good enough reason to go after this. Do you remember what I showed you? There is a lateral ischemia. Yeah. Okay, so the operator did try. Okay. Maybe I went too fast. So you happy with the balloon inflation on the left? Okay. So what do you do now? You don't have IVAS. It is a place, trust me, in the United States, we published in the Nevada state a huge number of patients. We divided the geography, and then we saw the MI outcome. The MI outcome was 4 to 5 times higher mortality in remote areas. So you talk about access to healthcare and system of care, this is huge. So what do you do now?
I can use an NC balloon.
Okay. He tried NC balloon, did not get the result. Next balloon. Okay. They have actually, the lab where they do, they have IVL. So we'll proceed. Actually, I appreciate it. What do you think?
I think in this case, if you go to the baseline angle,
Yeah.
there is some missing there. I mean, there are marginal, who's marginal?
That was.
Yeah.
Telling that the
CTO.
It should be big one.
Yeah.
no, it's a because whether it is engineer producing or not, that's a question also.
Yeah, but
Because this ostium L6 and the T3 flow in the group,
yeah.
because your artery is in the group which you are treating.
No,
The-
it is
almost in the group. Yeah, there are some minimal like LPD like branches there, but the in the middle, yeah, in the middle, it is blank.
But there is no collateral going. There is no way
That
to
means
know.
whether some adequate occlusions are there or not.
No, the patient is coming as an outpatient.
Yeah, but sometimes whether it is happened because obtuse marginal burns only give some lateral ischemia, but may not have that much, the ACS-like symptoms all the time. But whether the operator has tried for that one to open or not, because this is you see, this is here some
Yeah.
thrombotic area. I was telling that one.
No,
that
there is
this-
there is no. This is like a,
If you look here, you see some contrast also. At this point.
faint.
Maybe you have some microchannel.
Yes, microchannels. Yeah. So question is what we do. So the operator question is it going to do any benefit, or you want to open the ostium and then try the OM?
Actually, what will be my strategy in this case, I will go with intravascular imaging. I'll see how much LAD is diseased on the ostium. If it is not significant, I will limit my treatment only to circumflex and that's it. That means I'll try also to open the marginal.
Of course. So let me see. So he sent to us, and then we did the LAD, IVUS, and then make sure the LAD ostium is good. Then we did the circumflex, and then we did the shockwave and we are able to get a good result. Then we did the IVUS again for the LAD, and then we came out good. Now, I just want to tell you, I did not see it
Why do you have
after I opened this.
Why do you have positioned the stent there in LCX?
Yeah, with the few starts into the left main. But I did the LAD. But I did try the OM. I did not try long. I did not see it in case, you know how it's like. Yeah. So, but what I'm saying that in this case, that we need to make sure that we understand the limitation. There is no need to be hero. So the reason he did not do it, he called me. And I said, do not try that. Because in case you have a nasty complication, you don't have it. This is like a standalone cath lab. And our new attendings go there, they do the diagnostic and low risk procedures. And then if there's a complicated, then they send to us. So that's why I think it is reasonable to just refer. Yeah. So CTA shows extensive calcification in the distal left main and prox LAD. And it is really getting worse because the CTA is now read, many places read by the radiologist, and you can't tell what they are saying. So you need to see yourself. In our group, we do about 15 to 18 CTA a day. We read the CTAs ourselves. We have an assignment. We have like 13 interventionalists. We divide ourselves, and then we read this. So this was the cath. I'm not showing you the right. So what do you think about the left main? Lumen is good? But the LAD? Yeah. 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 By the way, the last case, the circumflex we did later, but the first time I could not get the IVUS through the circumflex ostium.
Yeah, that in IVUS it is possible.
Huh?
Because IVUS catheter in circumflex is just like,
Because of the angulation.
that's like a girlfriend relationship.
Yeah.
IVUS catheter never goes to the LCX.
I would not go that far. But so the question is, I took a different view, approach here. first I did an IFR, and IFR was 0.78. By the way, the FAME2, the DEFR, then all these, we always conceptually think is binary, right? But there's paper you can search that it is a continuum variable, meaning that Berman from Cedars-Sinai showed that ischemia, some people will say I have zero tolerance for ischemia, but ischemia burden has implication in terms of outcome. Meaning, Dr. Berman showed, the summed differential score and summed stress score and the net, right? So the larger the ischemia, then the worse is the outcome. And his disciple, Hakamovich, produced this again with coronary anatomy. It's a fascinating story. Similarly, the IFR is actually if it is I have done IFR in 95% stenosis patient just to see what it is. And it's just amazing that it drops to like 0.6. So 0.78, but the fellow tells me, I think you should do IVUS, And I said, okay, we'll do IVUS. But we did. But I'm saying, and Imad is here and Chowdhury is here, I will ask you guys about a question after this. Any question for you, how you do this case? Calcium score extensive. CTA, we need to get this. If you see the CTA, you can, like what do you call the video PlayStation? You can curve it, check it, and you can do vessel tracing. It is good. You can get an idea. Even for a mid LAD, you need to look at the prox LAD. If it is a tortuous, it gives you an idea that I will be having trouble in delivering the device. So CTA that way is amazing. Yeah. The calcium is high, calcium score. Now, it is not possible to get from the CTA that is superficial or deep calcium, but you can get a fairly good idea. If the lumen is compromised in the CTA, that means it's really bad. What do you want to do in this case? Same thing, if you do approach the balloon, non-compliant balloon, and you have all the tools, if you dissect, but if you don't dissect, you need to prepare. So my question, the reason I'm showing this, we did the balloon process, and then, good, we can put the IVL, and then it's focal lesion, not too long, so it's good, and we got 0.96. If I did not do IVUS, will you be happy now that with that angiogram and this IFR?
Yes.
Thank you. I love you. so it reduces cost.
No, actually, if you were based on FFR, you finish with the normal FFR, I think no need to go for IFUS.
Yeah, but I loved your comment because what is the borderline? I don't want to be on the fence post. If it is 0.91, if they say that if you jump 0.10, full 10 points, it's a good thing. But I really want to see 0.91 above. But this is probably better, 0.96, 0.97. So you're not on the fence. So clinical monitoring of the patient. Patient is getting ongoing chest pain, who came in from home and now getting chest pain in the lab. Something is not good. And then you claim that your angiographic picture is good, you still need to check out. So what I'm trying to make it clear that we still need to be clinical, the EKG changes, angiography, still critical. And after that, we can use physiology, some kind of assessment. And that's because we are striving for excellence, and we need to have some kind of assessment, physiology or anatomy. In some situations, you might need both. But I'm already happy.
But my question is that because in real world, in this part of the planet, because in your part, when you use these things, you have some reimbursement in your pocket also. But this is not here. like
Well,
like
wait,
for
hang on,
everything,
hang on,
for
hang on,
everything.
hang
No,
on.
it's a
No. This is
because,
actually
no, I'm telling about this case like this. You
No,
have
no,
used
but
you have
Saidu.
used CTA, you have used FFR or IFR, and then you have used IVUS, and then used IVL, and then you have stented.
right.
So 5
So
things.
just that you know,
For any case.
Saidu, let
in
me
this-
finish. If we use IFR, we do not get any extra reimbursement. There is no reimbursement for the IFR. So, no, for in the US.
Not in that sense. I'm
No,
telling
no,
that
no.
you are free.
But if you
You are
do,
free
but
from
in the-
going to jail.
No.
Because IFR
Yes,
is low.
yes. But
That's
if I'm
true.
thinking about the cost.
Yeah,
Let's put that
yeah,
aside.
that's I'm telling, that
The
5
cost,
costs.
we need to contain the cost because I'm running the lab also. So, like in the US, there is analysis, David Cohen did it, that if you use more than 1.5 stent per vessel, then you may not get cath lab profitable. So it is important that.
No, I'm telling for this case.
Yeah, but
like,
just to
if
let
we
the
don't have
IFR, the doctors are not using IFR, they are using IVUS because physician reimbursement is there. But I'm taking that aside.
No, that
But
is
it-
aside. I'm just asking that one. I'm telling for the practical situations here also, that 5 steps you have followed here. So, for this case, with a angina, with a typical angina has come here, what would be the approach here? We will go for a
So
CTA?
before you criticize me,
We'll not-
let me tell you something.
telling the-
No, let me tell you something. I am showing you the correlation. If you are convinced and Imad is convinced, then we can move forward to do it without IVUS. That's what I'm trying to get at.
Yeah, that's-
But just to convince you, I did the IVUS
No,
as well.
I'm trying in a different way, in a different angle. Like in our hospitals, when a patient will come with typical symptoms, whether anybody of you are sending the patient for CT angiogram or directly for the angiogram. Everybody will go for the direct angiogram, right? এখন your angiographic view is not that much convincing, right? If you don't have the CTA picture, you didn't go for to dig deep, to go for the IFR, to go for the IVUS, because angiographically it doesn't look that much significant initially, the angiographic picture. Patient has complained, patient has chest pain, but angiographically is there, and the hospital doesn't have the IFR. What he will do?
So
Then
I'm
he
trying
has to
to-
go back to CTA again, and to do the CTA, the patient will
No,
tell
no.
why I will go for CTA.
I think you are getting it wrong because what I'm saying that it is not this part of the world or that part of the world. After the ischemia trial came in and before that the Scott Hart, we now know that to start with for the evaluation of a stable coronary, CTA is a very good tool to start with. But the problem is when they come in, I call it's the power of 0 or negative. CTA is good to exclude those. But if, and cost-wise, in the US now, they are embracing the CTA because the cost of the CTA is $599. I can give you the cost.
That's why I'm telling, here it is almost equal in both angiogram and
I
CTA
think
in our
even
country.
if the states are reimbursing, that is not a good rule to use it.
Yes, I agree.
Because, of course, over 50 years old, every time, if it is not completely normal, every time you go for angio,
Yeah,
every time.
yep.
So,
Yep. So but here, we cannot compete on that in Bangladesh because the angiogram is how much?
Same process,
No,
same price.
14,000 taka, right?
No, same price.
Huh?
20,000.
Which is what? 200?
Yeah, 200.
$220. It is far cheaper than, and
No,
we all
your
agree.
your CT angiogram also $200.
No, CT angio is $599.
Here.
Oh, yeah.
Here same price. So the patient will ask us, the why I will pay twice, because you have done the CT angiogram, now again telling you to
But
go
this
for
point
the
is, Saidu,
angiogram.
I am not proposing to do CTA here. I am telling you that if you are doing angiogram, do the angiogram. But to evaluate further, we cannot have this stable coronary and do stenting without an objective evidence of ischemia. We simply cannot, unless you are talking about 95% stenosis or proximality. Yeah.
Let us say I will start with ischemic test
Yep.
with this patient.
Yep.
If ischemic test is negative,
Yeah.
I'll not do any other
Yep.
thing.
Exactly.
If it is positive, I'll go for angio.
Yep.
Angio.
Yep.
And
Yep.
I think this is the easy way to do it.
Yeah.
Less costly, and I think more safe for patient also as well. He will not get to irradiation.
Yeah.
And 130 ml contrast.
What are you asking?
No, not 0.96.
0.78.
0.78. Initially it's 0.78. Later it has been, after stanting, it has become 0.9.
So this, yeah, the Lima to LAD, vein graft to diagonal, vein graft to PDA, vein graft to OM, chest pain, anterior ischemia. Lima to LAD is atretic, and then this is the LAD. So I did not give you all the pictures, but if you are going for intervention of the LAD, what will you do? And this is the previous cabbage and left atrial appendage clip, if you want to know what that is.
You see, angiographically, it's a severe calcification. Angiographically, you can understand, because you know that mild calcifications, you can't see in angiographically. Only 38% cases you can see. But in 66% cases, angiographically, you can also understand that it's a severe calcification. If it is so much predominant in angiographically also, means it's a severe calcification. So severe calcifications mean whatever the armamentarium you have in your hand. So you have to start upfront with that armamentarium. Don't have any dilly-dally thing that,
So let's
okay,
say you have everything in your toolbox. What will you do in this situation?
If you ask me, then I will go because I love IVL. So if ask me, because it's not like Disrupt Cat 4 is telling more than 42 millimeter calcium is less than 42 millimeter. But you know that you can also extend that one. So first vessel bed preparation as much as you can with the balloons, whatever you want, and do an IVUS, and later on go for an IVL and make it clear.
Okay, so let me tell you the delivery catheter for the, we go with the wire, and then this is like a mamba. In the US we call it. It's a very low profile balloon, and with the help we wire. Even the mamba is not getting through.
Then you can't take the IVL because it's not going there.
So, and I cannot even wire. So I jam the mamba, and then I put the wire to rota floppy. Even they don't recommend that, but somehow I got lucky, and then after that I did the rota, and after the rota I use a long balloon, and then we came out. Oh, where is the final picture? And then we are able to put the stent there. But by one over the other, how do you choose? There is no right and wrong, but in a long lesions, it's too much because IVL balloon is very short, and then you may not may get everything, cracked, so it may not get. But if you do use the IVL in this situation, I usually like to use a long balloon, 30 balloon, and see that we get full inflation before starting to push the stent, because you may not get a full stent expansion. So this is a pre-transplant patient, and the dialysis, and I said it's okay to go, but then they say no. Then we did the ischemia, and then it was positive. And it's a long lesion in the RCA. And here, I thought that we'll be okay with the shock wave, and then we got a good result. So we can use in combination also with anterior ischemia, EF normal. Look at this one, calcified, little tortuous, And I think we also get a lot of, I cannot tell you, there's no evidence in the literature, but when you wear, then you can get a feel about the lesion.
Especially the nodules.
Yeah, for sure. And I was not getting a good feeling, so I said, it's probably better to do CSI, and then after the CSI, we use the IVL focal, and this was the final result. So last case. So this is 82-year-old.
Sir, just what is CSI?
Oh, sorry. This is it's an orbital atherectomy. The company's name is CSI. I'm sorry. Yeah. So I don't know how you can get away from using rota or CSI for that matter, orbital atherectomy, because many interventionalists are much more comfortable, of course, with the IVL. It's much easier, but it may not be that easy, and sometimes you may end up in a complications, So this patient had this diagnostic cath, and this was the distal left main. I think one of the cases Fazila Appa showed is like this. So what do you want to do with this case? The surgeon turned down the case. Patient has a previous bioprosthetic aortic valve, and then this was the chest. And after they saw this, they said that, are you out of your mind? So, yeah. So in this case, and the guy is really gets angina on when he does any exertion. And he loves his horses, and he gets angina as he tries to feed the horse. It was that bad. So what do you want to do? Of course, it's a distal left main. We checked the EDP, LV function was not normal, previous surgery. So I put an impeller, but my question is, you secure the hemodynamics, but now the strategy, right? So we need to optimize the hemodynamics and then the strategy. So I initially thought that we do rota on both. Rota left main to LAD, rota left main to CERT. But things went south after the rota to left main to LAD. Little slow flow. Any thought? Any change of strategy? Any question?
Actually, I think it is just small comment. I think this, from angiographic point of view, if you look on this distal bifurcation, I will define it simple bifurcation. And my intention to treat in this patient is provisional stenting. So in this case, I will not go for any treatment on circumflex. Because I think you have heard today many discussion about simple, complex, and I think it is good to define what we intend to sample. This is something of simple bifurcation.
Yeah. So let me tell you this, that after we did this, so it is not a bad idea to have two brains better than one brain, right? So, and he said, no, the circ is not that bad. So I said, okay. So, and then this looks like this. And then we did. And then I was getting encouraged that we may be able to get away. But the flow wire, if you believe in this, flow wire came bad on the circ as well. It is not horrible, but it is like 0.88 or something. So then patient now getting chest pain. And its flow is not the great. So what is the best bailout strategy? This is actually a few years ago. By the way,
So you have done the classic crash.
yeah. So this is a few after the DK crash, as Ramesh was pointing out. In the U.S., we are now going for DK crash. But just to assure Imad, we are doing, actually in my lab, I'm doing more flow wire of the side branch. Even for left main, I'm doing IFR and also IVAS. IVAS because if the IFR post remains good, I just need another IVAS just to assure me. But if the IFR is good, my experience is that it is good.
But for young interventionists, I think when you are doing,
this. No,
yeah, when you are doing preventive stenting, if you do not have any compromise on side branch, you do not have any change on ACG, any chest pain, with good flow in side branch, I will not do any other thing. I go
because Hafiz Bhai is also telling that IFR was significant, but not that much. He's telling also.
But listen to this.
This is my view.
Clinical, he is still emphasizing the clinical and angiographic EKG changes. These are very important because if the, little pinch, particularly in acute setting, in the acute coronary syndrome STEMI, if there is a side branch, I just do a flow wire, and then if that, and sometimes I'm pressured by the fellow particularly, I use, and you may criticize, I use Cangular, just to give for 4 hours because of thrombus burden and all this.
This is a very dominant circumstance.
Yes,
So
yes.
that is another
Yes, another,
way to
yeah,
evaluate it
yeah,
much
much better than, yeah. Because, the Korean studies, all these, the Achilles heel, the ostium of the cert, it comes back and haunt you.
Yeah, but you know that obviously it is not fulfilling the definition criteria at all. So
Which
it's
one?
not a two-stent strategy. Upfront two-stent strategy is not because it's not at all
Change my
fulfilling.
strategy,
Yeah.
but you should consider every time the dominance also.
Yeah,
In this case, I will not change my strategy.
yeah. But also things may happen and you may end up with an ad hoc strategy. Yeah, if things go wrong. So this is, we did, follow this, that the pre-imaging and the post-imaging, the morphologic assessment, length, diameter, and then post-procedure, you apposition, expansion, and the question is any medical dissection, right? So apposition, I don't know how much apposition we need, but expansion we cannot compromise, right? And it can be both issue, because if you have a 4O vessel and you have a 3O stent, your stent is expanded, but it's not opposed, right? So I think we should be familiar with the terminology well, what we mean by that. And look at this.
What is the distance to call malapposition?
Okay, so see that? 0.3 millimeter wall, more than 3.3. So, and in the IVAS is helpful, and we're getting a lot of help from this, and I'll end here, that you can do a stepwise approach, the balloon, escalating balloon, high pressure balloon, but be prepared that if things go south, you have enough expertise in-house. That's another important thing. And then use your toolbox, prepare the vessel, and then come out with the best, optimal PCI, and assess the lesion. And it is all in the preparation. Yeah, thank you.